Ladies and gentlemen, please welcome Dr. Paula Johnson.
Thank you. Well, 1993 was not a good year for wine, but it was a great year for women's health. In 1993, President Bill Clinton signed the NIH Revitalization Act into law. And this law mandated the inclusion of women and minorities in federally funded studies. And over these past 20 years, in many ways, this law has worked. Women are now routinely included in clinical trials, and we now know that women and men experience disease differently. In fact, an entire new field of women's health emerged to answer these unknowns. Now, it was almost 20 years ago that we knew almost nothing about women's health beyond our reproductive functions. But today, we know that every cell has a sex. This is a term coined by the Institute of Medicine, and what it means is that men and women are different down to the cellular and molecular level. And we see these differences across all of our organ systems, from our hearts to our lungs to our joints to our brains. But unfortunately, so much of what we've learned is often overlooked. There is so much more for us to do. The Connors Center for Women's Health and Gender Biology at the Brigham is dedicated to exploring and discovering why these differences occur and to translating those differences into clinical care. Now, what I'm going to do this afternoon is share with you 4 examples of diseases where there are clear sex differences, but where there remain roadblocks in both research and clinical care. Let's start with heart disease. Heart disease is the #1 cause of mortality in women in the United States today. This is Linda. Linda is the face of heart disease in women. Now, Linda was diagnosed a few years ago with heart disease, and in fact, she had a stent placed in one of her arteries. Now, when Linda's symptoms recurred, she went to her doctor. They did the gold standard test, a cardiac catheterization. They didn't find any new blockages. She went home. Her symptoms got worse. She had to stop working as a landscape architect. She then went back to her doctor. They did yet another cardiac catheterization. Still no answers. That's when Linda found us at the Brigham. When we saw Linda, we, yes, did another cardiac catheterization, but this time we did an additional test called an intracoronary ultrasound. And what this test does is it uses sound waves to look at the artery from the inside out. And what we found was that Linda's disease didn't look like the typical male disease. Now, the typical male disease looks like this. There's a very discrete blockage. You can see it. Linda's disease, like the disease of many women, looked like this. It's more diffuse across the entire artery, and it's more difficult to see. So clearly, the gold standard was not the gold standard for Linda as it is for many women. Now, the good news is that we were able to treat Linda. Linda's symptoms resolved. She went back to her life, and I'm glad to report that she is doing well. But Linda found us. We found Linda's disease, and for too many women, that's not the case, because sex differences are not being considered when diagnoses are made. Now, let's talk for a minute about the treatment of heart disease. A landmark study was published about 3 years ago that asked the very important question: what are the most effective treatments for heart disease in women? The investigators reviewed papers written over 10 years, and they had to throw hundreds out. And when they went back and looked to find out, well, why did we throw those papers out? What they found was that 65% of the papers that were excluded because the results didn't differentiate between women and men. Now, what a lost opportunity. The money had been spent, and in fact, women were included in the studies. But because the investigators didn't differentiate between women and men, those studies could not contribute one iota to the very important question: what are the most effective treatments for heart disease in women? Now, another area where there's significant opportunity is in the fields of reproductive health and cardiovascular health. Today, those fields mainly live in silos. Now, why is that important? We know that women who experience certain diseases of pregnancy, like preeclampsia, which is high blood pressure and proteinuria, made famous by Lady Sybil, for those of you who are Downton Abbey fans. So preeclampsia, gestational diabetes, which is diabetes of pregnancy, preterm delivery, or low birth weight. So women who experience these disorders of pregnancy are at twofold increased risk of cardiovascular death over their lifespan. And it's not only them. Their children are at increased risk of cardiovascular disease. Now, why is this a problem? If these two areas live in silos, it is likely that when a young woman goes to see her internist, and that is if she has one, when she goes to see her internist may not know that she's had these complications of pregnancy. And even if her internist knows, he or she may not know the connection with heart disease. And this is important because it takes away a woman's ability to think and to really think about changing her risk factors for not only herself, but for her children. So it's not only important that we educate women, that we educate healthcare providers, but we must transform the healthcare system. And we are doing just that at the Brigham by developing new models of care that integrate reproductive health and cardiovascular health. So let's move on to our next example, lung cancer. Lung cancer is the #1 cancer killer of women in the United States today. And each year, it kills more women than breast cancer, ovarian, and uterine cancers combined. Now, a startling fact is that women who have never smoked are 3 times more likely to be diagnosed with lung cancer than men who've never smoked. Yet, when women are diagnosed, their survival tends to be better. Why? Well, here are some clues. Our investigators at the Brigham have discovered that there are certain genes in tumor cells, in lung tumor cells, that are mainly activated by estrogen. And when these genes are overexpressed, it's associated with an improved survival in younger women. Now, this is an early finding, and we don't yet fully understand the relevance and its connection to treatment, but it's research and findings like this that have the potential to save the lives of both women and men. Now, here's an example of when we considered sex, it drove the science. A few years ago, investigators were looking at a new drug for lung cancer, a new chemotherapeutic drug. And when they asked the question, whose tumors shrank, what they found was that of those whose tumors shrank, 82% were women. They then asked the question, why? And it turned out that the genetic mutations that this drug targeted were far more common in women. And what this has led to is a more personalized approach to the treatment of lung cancer, one that takes into consideration sex. Our new women's lung health program, the first of its kind in the country, is undertaking research and clinical care models that are answering these questions, are delving into these questions from lung cancer to asthma. So let's talk about depression. Depression is the #1 cause of disability in women in the world. We know today that women are 70% more likely to experience depression over their lifetime. Yet in spite of this high prevalence, women are misdiagnosed 30 to 50% of the time. Now, women are more likely to present with symptoms of fatigue, sleep disturbance, pain, and anxiety, and these symptoms are often overlooked as symptoms of depression. Now, some of our investigators have discovered that there are very significant sex differences in the areas of the brain that are connected with mood. And what they found is that if you put women and men in a functional MRI scanner, that's the kind of MRI scanner that's showing how the brain is functioning when it's stimulated. So you put men and women in the functional MRI scanner and expose them to stress, you can see the difference. Now, we believe that it's findings like this that may hold some of the clues as to why we see these sex differences in depression. Now, with all of these differences across this domain, what we also know is that 66% of the brain research that begins in animals is either performed in male animals or the sex of the animal is not identified. I would venture to say we can do better. We must do better. And why are we leaving women's health to chance? And then there's Alzheimer's. A woman's overall lifetime risk of developing Alzheimer's is near twice that of a man. And it's not just because she lives longer. As we all know, this is a devastating disease, not only to its victims, but to their families. And it is costing our country today over $300 billion a year. Investigators are just beginning to recognize that by studying these sex differences, that it may provide clues to the basic biology of Alzheimer's, which we hope will lead to more effective treatment and hopefully to prevention. Our own new Ann Romney Center for the Study of Neurologic Disease has the ability to attack these questions and hopefully bring us answers. So these 4 examples that I've shared with you today, heart disease, lung cancer, depression, and Alzheimer's, provided the framework for a report that the Connors Center published and launched at a National Women's Health Policy Summit in March of last year. The title of the report, Sex-Specific Medical Research, Why Women's Health Can't Wait. What the report did was it laid out the progress that we've made over the past 20 years, but it also identified the roadblocks in research, in clinical care, and in medical education. We made a series of recommendations on how to chart the course forward, and we asked for a recommitment to sex-specific research and to women's health. We have seen progress, and we are so thrilled to report to you today that we have recommended a multi-stakeholder approach, and there's been progress and momentum on Capitol Hill. The NIH has said that it will soon require the inclusion of female cells and female animals in preclinical research. And it will also soon require the inclusion of adequate numbers of women so that we can get more robust and more meaningful results. But we also believe that each and every one of you can play a role in moving women's health forward. So I'd like to suggest that if you're a woman, that you ask your doctor, is this disease or treatment different in women? Your doctor may not know the answer, but if you ask the question, he or she will go looking for the answer. We'd also like to suggest that if you're being started on a new medication, that you ask your doctor, is this the lowest possible dose of medication that will be effective? Men and women metabolize drugs differently, and it's not just because women are smaller. And by asking this question, you may not only achieve a better outcome on the drug, but you also decrease the risk of complications. And then lastly, if you are involved either philanthropically or as a volunteer or through your investments in a disease-specific organization or in healthcare or in the pharmaceutical industry, that you ask the question, do you consider sex in your approach to disease or discovery? If we don't ask the questions, who will? We strongly believe that now is the time. Some post-election polling that the Connors Center had performed after the midterm election showed that a majority of voters, yes, women and men, believe that the health of women should be a priority, not only for policymakers, but also for the healthcare system. And in this advanced stage of science, where we are today, we know that sex differences in research is fundamental to the future of precision or personalized medicine. The United States has the most advanced research and clinical operation in the world. We owe it to ourselves, to women, to men, children, and to future generations, both here in the United States and around the world, to make sure that our research, our clinical care, and our medical education applies as much to women as it does to men. That we have the right strategies for treatment, cure, and prevention. Our legacy at Brigham and Women's Hospital can be to improve the health of women for this generation and for generations to come. Thank you.